I'm very happy to announce our next speaker. He's the keynote speaker, and this is for Dr. Carlos Del Rio, and he will be speaking on gender and racial disparities in outcomes in patients with COVID-19. And what could be more timely than this pandemic that's not only affecting the whole world, but it's really very prevalent here in Georgia right now, and I'm sure we're going to hear a lot about that. Carlos Del Rio is a distinguished professor of medicine at Emory University School of Medicine and professor of global health and epidemiology at Rollins School of Public Health at Emory University. He's the executive associate dean of Emory at Grady, principal investigator and co-director of the Emory Center for AIDS Research, and co-principal investigator for the Emory CDC HIV Clinical Trials Unit and the Emory Vaccine Treatment and Evaluation Unit. After going to medical school in Mexico, he came to Emory, where he was a chief resident at Crawford W. Long, before it was called Midtown University Hospital. And then he returned as a faculty at Emory in 1996. He's passionate about the diagnosis, care, and access and compliance of his HIV patients and using retroviral agents. He's also compassionate and involved in gender diversity, gender equity, and prevention of sexual harassment. If you've been on the news in the last 3 months, you've seen Carlos Del Rio, not only on NBC Nightly News and CNN and every local as well as national news coverage, but also radio coverage. He has become a leading authority in COVID-19 and is definitely the region's most highly listened to advisor. He's going to talk to us now. I would like to tell you that he has been elected to the National Academy of Medicine and the National Academy of Science, an extremely important achievement for all researchers. Here is Dr. Carlos Del Rio.
Well, thank you very much, Gina, and thank you for the organizers of this meeting. I'm particularly honored to be on this, as you know, especially as you celebrate Dr. Wenger's birthday. Nanette, as you well know, more than everybody else, is just simply an inspiration. She's been a mentor to me. She continues to be a mentor, a friend, a colleague, and I would tell you that there's nobody I know works harder than Nanette. When I get to the Grady parking lot, she's usually there before I do, and she's always telling me what could be improved, what could be done better, what we can do to make things better for patients. I'm going to be talking to you about COVID, and I'm not going to spend a lot of time going over specifics, but let me just give you a little bit of an update since this is a group of cardiologists. Coronaviruses are a very large family of RNA viruses that infect many animals. So for example, cats can get coronavirus disease and multiple other animals do. And they're named for their crown-like spikes on the surface. They cause about 10 to 30% of common colds, but they also can cause very severe disease. And there's illnesses such as SARS and MERS that are manifestations of severe coronavirus disease. COVID-19 is a new virus. It was a new coronavirus. It was discovered in December of 2009 in the city of Wuhan, China. It's like many other coronaviruses, its natural host is likely the bat. And because it's a new virus, there's a lot of things that we still have to learn about it and are learning very quickly through research. This is a phylogenetic tree, and what you can see here is that the SARS coronavirus belongs to the lineage B coronaviruses, which are coronaviruses that use the ACE receptor. And you can see here the SARS coronavirus is here, and this 2019 SARS-CoV-2 is right next to it. So it belongs to this group of coronaviruses, as opposed to other coronaviruses like the MERS coronaviruses in this lineage C, which utilize the CD26 receptor. So this is more similar to the SARS coronavirus, and it uses the ACE, the angiotensin converting enzyme 2 receptor. That, of course, for you in cardiology, this is something that you're very well known and you use all the time. this ACE receptor, as you well know, it's in the surface of the cells, and it permits the attachment of the virus, and it also allows to the enter into the cell. But as we know, this virus is this receptor is not only in the lungs and the respiratory tissue, but it's also in the heart, in the GI tract, and in the kidneys, and that may explain a lot of manifestations we see with this disease. There's been a lot of debate about the transmission of this virus, but in general, we can say this virus is spread through respiratory droplets, and we can talk later if you want to about whether aerosols play a role or not, and also by contamination of surfaces. What's important is that this virus is transmitted before the onset of symptoms, or even in people that don't have symptoms. And because about 35 to 40% of people don't have symptoms, that makes the control incredibly difficult because you can be asymptomatic and yet be infectious. It can be found in stool, but it's unlikely a source of transmission. And there has been very rare cases of perinatal transmission. The incubation period is about 5 days. It can range from 2 to 14, or a little bit, sometimes even a little bit longer. And about 80% of the illnesses are very mild. But about 20% of the patients are hospitalized, and some of those hospitalized require intensive care, require ventilation, and they don't do well. So where are we today? Well, you know, globally, there are about 21 million cases. There have been about 750,000 deaths. In the US alone, we have over 5 million cases and 170,000 deaths. We are doing now a lot of testing in the US. We've done over 68 million tests, and we're doing about 200,000 tests per million population. And there's now 3 states, California, Florida, and Texas, that have over 500,000 cases. Georgia's number 5 in the number of cases and number 7 in the cases per million population. But Georgia now has the highest case rate in the United States, and it posted the highest single-day death rate on Tuesday at 137. Brazil is number 2, and India is number 3. And if you think about the US, Brazil, and India, together they're pretty much represent a half of the total burden of disease globally. But Russia, South Africa, Mexico, and Peru also have over 500,000 cases now. So this is what the epidemic looks like in the United States. And here cases have continued to surge. And currently we have primarily in cases that open first, and we have about 8 states where cases are increasing, about 21 states where cases are kind of stable, and 25 states where cases are decreasing. And you can see that at 5 million cases, we're currently having about 53,000 new cases per day, which is about an 18% decrease from the previous 2 weeks. So we're beginning to see some decrease, as you can see from the heights up here. On the contrary, deaths came down and are starting to go up. And right now there's about 1,000 or so deaths per day. And if this trend of 1,000 deaths per day continues, by December 1st, we will have over 300,000 deaths from this disease in the United States. This is currently the hotspots of this disease, and the hotspots of this disease are primarily in the southern states, in the southern US, from Arkansas, Tennessee, all the way south. And you can see that, you will know that this is also the area where we have more diabetes, more hypertension, more heart disease. So obviously, the concern is that this is a junction of multiple diseases sort of playing on each other. So here, look at some sort of national metrics. You can see that the daily tests are about 800,000 tests per day, but came down a little bit. The daily cases are about 51,000, again, are coming down. Hospitalizations went down, then went up, and then are starting to come down again. And deaths are staying flat around 1,000 deaths per day. So what about Georgia? Well, you can see in this heat map of Georgia that the hotspots, even though Atlanta still has a lot of cases per the population, really now a lot of the hotspots are in rural counties. And I think this is really important because, the first phase of the epidemic in March and April was primarily concentrated in cities. But now we're seeing cases in rural communities, and this is not only in Georgia, but in many other states. This is really what's driving the epidemic now. A lot of rural spread. In Georgia, we're having close to 4,000 new cases per day, and we're having about 100 deaths per day. and this is where epidemic is. So you can see we're one of those states that's considered flat because, you know, the new cases are not going up, but they're really not coming down. They're pretty much stable, but deaths are clearly going up. So this is a website I recommend, which is called COVID Act Now. And you can also look at the state, but you can look at county level information. And you can see that we're having 31 cases per 100,000 population. And that's considered a dangerous number, you know, it puts us in the red zone. You would need to be below 10 cases per 100,000 to be down in the green zone. Our infection rate is 1, our positivity test has come down to about 11%, but our ICUs are still pretty packed at 95%. And we're really not doing a good job contact tracing. Only 8% of cases are being contact traced. So we're really in a very difficult situation in Georgia as far as the control of the pandemic is concerned. And again, you can see here in the maps from the Georgia Department of Health, again, the cases being pretty stable. And you can see here the mortality, how the mortality has really jumped quite a bit. So this is the bottom line where we are in Georgia today. I would also recommend there's a website called ATL Strong. This is a website maintained by the Mayor's Office of Atlanta. And this is the latest data from that website that you can see. We try to track their, you know, number of cases, hospitalizations, the positivity rate, and you can see we target it and we see where things are and how that responds to decides what phase of the opening we are at. So hospitalizations at the state level are about 3,000 people with COVID hospitalized. And I just point to you that back in June 7th, we only had 743 people hospitalized with COVID. So in the past several weeks, we went up, in 3 weeks, we tripled the number of patients. And we really, well, coming down a little bit, or at least not going up, they're pretty stable at around 3,000. And as a result of that, you know, the state and the regional bed capacity and ICU capacity is pretty tight. And you can see a similar thing in the Metro Atlanta region. So let's talk a little bit about disparities, and let's talk first about gender disparities in COVID. I mean, there are several studies that suggest that men with COVID do less well than women. And this is not new for COVID. A higher fatality rate was seen also for men with both SARS and with MERS. And one hypothesis has been that the estrogens are actually protective. And there's a couple of studies suggesting that postmenopausal women don't do just as bad as men. But others have suggested that this is because there's a high concentration of ACE2 receptors that are expressed in the lung tissue in men, and that may be that therefore they get inoculated with higher doses. But a lot of us think that it may be just an issue of lifestyles. You know, men are more likely to have diabetes, hypertension, to smoke, and that may be the reason that explains the differences. But what we know for sure is that mortality and case fatality ratio is higher for men, and men have a higher prevalence of comorbidities, so pre-existing conditions, heart disease, hypertension, diabetes, renal disease. Men also have higher risk behaviors. They're more likely to smoke, and they have occupational exposures. And it may be actually an issue of innate immunity, but it could also, as I said, could be biological differences. And I think this clearly needs to be studied further. But you can see from this study from China very clearly that men in the dark bars versus women, men, as far as mild to moderate to severe disease, there's no difference. But when you get to a serious disease, when you get to people who are in the ICU, intubated on a vent, men are more likely to be have severe disease, serious disease than women. And this is not exclusive from China. When you look at countries with more than 1,000 deaths, and you look at the male to female ratio and the death ratio, you can see that regardless of which country you're looking at, men are more likely to die than women from this disease. Now, again, this could be due to other things, right? Men are less likely to practice social distancing. Men are less likely to shelter in place. Men are less likely to do all the things that we know protect you from this infection. So it simply, could this simply be reckless behavior of men as opposed to more, careful behavior than women? So I want to show you this data, moving on to ethnic disparities. this data that came in from Georgia. This was a study done by colleagues at Emory and in Georgia and at CDC. And you can see here the age distribution of hospitalized patients. And while a lot of the patients are older than 60 years of age, and the median age was 60, the reality is that almost 30% of the patients in Georgia were under the age of 50 who were hospitalized. So when people say, well, this is a disease just of older people, that's not necessarily true. The other thing that you see here is that there's 83% of cases hospitalized in Georgia are among African Americans, and this compares to only 47% of non-COVID admissions at those hospitals. So obviously, there's disproportionate impact. We did not see in Georgia much of a gender disparity. 51% of the cases were actually in women. But we did see that 7% of the cases were lived in institutional settings prior to admission, primarily in nursing homes and in long-term care facilities. So what were the underlying conditions of this patient population? And, you know, a large number of people had no underlying condition. And I think that's something really important when you look at this. But do look at how obesity, diabetes, and other hypertension, the prevalence of comorbidities did not differ by race. So it wasn't like the African Americans had higher prevalence of comorbidities. That was not the case. Now, what happened to the patients? What were the outcomes and what happened to them? Well, you can see that the median hospital stay was of 8.5 days. And older patients older than 65 stayed in the hospital longer. And you can see that, you know, how many were admitted to the ICU, and the median ICU duration was 8 days, and median day on vent for patients that were vented was 9 days. And you can see here the mortality, close to 20% of patients died. But if you look at by age, if you were younger than 50, only 3% died, versus if you're older than 65, almost 35% of them died. If you were mechanically ventilated, again, the mortality was much, much higher in those that were older. And you can see that when adjusted you know, in this time to event analysis, Black patients were not more likely to receive mechanical ventilation or die during hospitalization. So again, you did not see a racial disparity as it relates to outcomes in our hospitals in Georgia. So I want to point your attention to this very well done, you know, publication, if you haven't seen it, in the New York Times, in which they looked at this issue of racial disparities in inequities in COVID. And you can see the cases per 10,000 population were 23 among white people, were 62 among Black people, and 73% among Latinos. But furthermore, when you look at the distribution by age, you can see that among whites, the great majority of patients were over the age of 80. While when you look at Blacks or Latinos, you don't see that distribution. You see really a much more, you know, a much higher impact of the cases in the younger age group, and primarily look at Latinos, where, you know, people in the 50 to 59-year age group are actually a large percentage of the cases. So obviously that also is a very important difference as far as the racial inequalities that we see. And again, look at this, the reported cases per 100,000 population as shown by CDC. You can see again the high number of cases per 100,000 population about Blacks, Latinos. And you can see here the deaths, how high the deaths are for Blacks and Hispanics compared to other groups. So the bottom line is that nationwide, Black people are dying 2.5 times the rate of white people from COVID. And that is something that we really need to think about. That you have, you know, mortality of 77 per 100,000 population versus 44 per 100,000 for Hispanics versus 31 for whites. Now, this is interesting because this takes an analysis of all the cases, and you can see here that for Black or African Americans, you know, they are 31% of the population, 39% of the cases, but 45% of the deaths. Contrary to that, look at Hispanics, where it's 9% of the population, but 20% of the cases, but only 6% of the deaths. So again, the percentage of cases and the deaths is not necessarily correlated among, you know, you have more cases there before you have more deaths. So further analysis is needed in order to understand this difference. Now, I will tell you that in Georgia, only 66% of the cases are reporting race or ethnicity. So it's been harder to do this analysis in Georgia than it has been in other places. Now, is it race or is it something else? And socioeconomic condition is likely to be that something else. And you can see in this analysis done in New York how really the driver of mortality, the driver of deaths, etc., was actually where you live, and was actually the zip code, and was actually poverty. So I like this quote from Mary Bassett, who says, the focus on comorbidities makes me angry because it's about who still has to leave their home to go to work, who has to live in a crowded apartment, get on crowded transport, go to a crowded workplace. And we just haven't acknowledged that those of us who have the privilege of continuing to work from our homes aren't facing those risks. So it really talks about this whole issue that it may not be race, it may not be anything but other social condition. It may be really a economic situation, a disadvantage that is driving the disease in minorities. So when you think about this racial, ethnic, minority disparities, you really have to think about those being more likely to work in essential industries, have increased exposure, they have limited PPE, they lack of paid leave. There's racial segregation by residential segregation by race. Blacks are more likely to reside in poor areas with a higher household density and poor access to healthy foods. And there's frequently multi-generational households, right, where the young adolescent or young kid gets infected and the community comes home and infects the grandma, and that's the person that ends up in the hospital. Then you add to that issues of lack of insurance, et cetera, that simply makes the disease worse. So I think in conclusion, we can say that sex is really a very important driver of risk and mortality in COVID. And we need further research to understand why this difference in sexual outcomes, why do men do worse than women? But racial and ethnic disparities that are the hallmark of this epidemic appear to be less about race and ethnicity and more about poverty and social determinants of health. So when you think about the disparities, there may be very, very different, and there may be, one may be more biological and more related to gender, and the other one may be more related to social determinants of health and quite frankly, structural racism. So with that, I'll end, and I wanted to leave plenty of time for questions and happy to have a further discussion on the topic. Gina, happy to answer some questions, and I don't know how you want to do that.
We have a few questions for you. Definitely, I think this is going to be a session where people are very interested in questions. So our first question is it true African Americans are more likely to be deficient in vitamin D, which may inhibit the immune response to COVID-19 and may contribute to increased death among African American patients? So your thoughts on vitamin D?
Well, vitamin D is sort of the vitamin that we all look for something, right? And there are some studies suggesting that vitamin D may be lower in African Americans, and that some people have tried to make a relation. But the reality is we have not seen any studies showing that, giving back vitamin D makes a difference. So, association does not mean causation, and I think we need to be careful about that.
Okay, another question. Melanated individuals have lower vitamin D levels, which may account for increased numbers in African American and Latino communities. Do you think that's possibly an active issue?
Again, I'm clearly not a vitamin D expert, but I will tell you that Ventam Precha and others who are big into vitamin D are looking into some of those issues.
Another question, besides social conditions and underlying diseases, you have identified biological factors have you identified biological factors increasing the risk for Hispanics or African Americans?
As I said, it doesn't look like it. Clearly, Hispanics and African Americans seem to have, or you would think, have a higher incidence of comorbidities, but at least in that one study that was published in the MWR out of Georgia looking at hospitalized patients, we did not see a higher incidence of comorbidities in those that were, in fact, we didn't see racial disparities in outcomes. But we all know that there's higher prevalence of diabetes, hypertension, and heart disease in African Americans. And for example, in Hispanics, there's a very high incidence of diabetes and obesity. And in fact, some people think that the higher, right now, almost a quarter of the mortality from COVID globally is in Latin America. And some people think that the high mortality in Latin America is driven by obesity and diabetes.
And you may recall, I reached out to you early on that it seemed like obesity was a big factor. Can you comment more on that? Do you think it's that they have a more inflammatory response, that their hearts are already somewhat compromised, that maybe their respiratory systems are compromised?
This is not necessarily new. We knew from influenza, we knew from pandemic flu back in 2009 that obesity leads to worse outcomes. It could be more inflammation. It could be more inability to have adequate lung exchange. It may be actually people with obesity have more hypercoagulable conditions, so they're more likely to form clots and do worse. But the reality is, I tell somebody that if you're, there was a recent paper in Annals of Internal Medicine saying that if your BMI is over 30, your chance of doing poorly with COVID are substantially higher. And if it's over 40, you really don't do well at all. So if your BMI is over 40 and you're under the age of 30, you really need to think about that patient of somebody over the age of 75. So that person is really, obesity is a major driver of poor outcomes in COVID. And, I can tell you when I look at the people who have died at Grady, for example, the great majority of those that were not older individuals, that were not nursing home residents, have been severely obese individuals.
Another question, what is your thought on herd immunity? I'm sure you've had a lot of that question. And is there going to be such a thing with COVID-19?
Well, herd immunity is an interesting concept. But we think that with COVID, you will need about 60% of the population either infected or vaccinated to get to herd immunity. Without a vaccine, getting to 60% of the population, right now, we have about 10 million Americans. Let's say there are about 10 to 15 million Americans that have been infected. Let's say there were 20 million Americans that have been infected so far with COVID-19. There's still 300 million Americans out there. So you would still need to get to 60% of the population. You still have 160 million Americans to go to get infected. And the estimates is that if you were going to get to herd immunity, you would probably be talking about not 150 or 60,000 deaths as we have right now, or more like in the neighborhood of 1.5 million deaths you would need to get to herd immunity. So I think while herd immunity is possible, the mortality risk of herd immunity is just so high at this point in time. Now, once we get a vaccine, that also means that you don't need to vaccinate everybody, right? If you vaccinate 60% of the population, you will get to herd immunity. So I think it's important that we know that we don't need everybody vaccinated. We just need a high percentage vaccinated. So I think we'll get to herd immunity with a vaccine. I think without a vaccine is not possible. It's possible, but the mortality will be just unacceptably high.
And the next question is, would you comment on how close we are to getting a vaccine and your thoughts on when we might have a safe and effective vaccine?
So I would say that those of us that work in vaccines, it's just been amazing to see how rapidly vaccines have developed. We went from discovering a virus and sequencing a virus in January to giving the first dose of a vaccine to a human in 65 days. And we are now in phase 3 trials. Emory has just recently started enrolling participants in a phase 3 trial. I think phase 3 trials will be completed by probably November, December. And I think somewhere between March or April or next year, we may have one or several vaccines that we can use for COVID. So I'm pretty hopeful. I'm actually very optimistic that we will have a vaccine. It may not be a perfect vaccine, but we will have a vaccine that will make a clear difference.
I have a question about treatments. Can you comment on some of the over-the-counter treatments that are so controversial in the news, and then some of the treatments we're using in the intensive care units?
So as far as treatment of COVID, the only thing that have shown to be effective for treatment are two things. Number one is an antiviral called remdesivir that was developed by Gilead. Uh, Gilead just submitted the NDA to the FDA this past week to get approval for the drug for COVID. It is used in patients with hospitalized and IV medication, needs to be given over 5 days, and in people who are requiring oxygen. The other drug that is shown to be effective in randomized control trials is dexamethasone. Dexamethasone actually decreases mortality in patients with COVID. So those are the two drugs that we currently have available. There's a lot of research happening. We currently don't have an oral medication, something equivalent to a Tamiflu that we can take by mouth when we have disease. But there's a drug, actually one drug developed by investigators at Emory called EID 2801 that is actually in clinical trials and that may be an effective drug to use that way. As far as the other treatments that have been tried, all of them have not been effective, and there's plenty of randomized control trials showing that hydroxychloroquine and azithromycin and zinc and also all sorts of things don't make a difference. So we really are in desperate need of better therapies for COVID, and I think a lot of research is happening in that direction.
We have a few more questions about vaccines. One asking, is it true that the theory of the influenza vaccine could reduce COVID severity?
I don't think there's any evidence that influenza vaccination will decrease COVID severity, but I would say that having an influenza vaccine will decrease your chances of getting another respiratory pathogens in the fall. So I would encourage you to encourage your patients to get their flu shot more than ever this winter season.
And our participants want to know what you think about Russia's vaccine and what they're claiming about their vaccine.
Well, you know, what Russia is doing is they have a vaccine that is an adenovirus vaccine, and it basically it's a combination of two adenoviruses. The first one basically takes the adenovirus being tested in the Oxford vaccine, the vector being tested in the Oxford vaccine and the AstraZeneca vaccine. The second takes the adenovirus being tested in the Chinese, the CanSino vaccine, and puts them together. And what the Russians have done is they have just said, well, you know, we got a vaccine, we're going to use it. This is a combination of the Oxford and the Chinese vaccine, and we're not going to do a clinical trial to show if it's effective or not. We're just going to use it. So they're skipping phase 3. So, you know, it may be the right decision, but I personally will not take a vaccine that hasn't gone through phase 3 trials. I would like to see efficacy and I would like to see safety before I give a vaccine. So I think it's a little reckless what they're doing.
We have a question from Dr. Pooja Mehta. Her interest is in microvascular dysfunction, and she wants to know if you think that the myocarditis with COVID is different from other viral myocarditis. Do you think it's more aggressive, and any autoimmune dysfunction afterwards, long-term in recovery or even years later?
Yes, I mean, that's a really good question. I think the myocarditis in COVID is a fascinating condition, and I think we need to understand it better. But to me, it almost reminds me of viral myocarditis followed by autoimmune myocarditis. It's almost like the virus causes disease and then precipitates and first an inflammatory and later an autoimmune response in which there's a lot of arrhythmias associated with it. I have seen a couple people with myocarditis from COVID, and it's very scary. They have very difficult to control arrhythmias. They have significant diastolic dysfunction, systolic dysfunction, and they don't do well.
All right, we have a few more questions here. They just keep coming. So can you comment on, once you've recovered from COVID, your antibody situation? Will you have long-term immunity or not? And what do you think the long-term implications are on the body's organ systems?
So yeah, so first of all, long-term consequences. The great majority of people with COVID will recover and do fine, but there are some individuals that are going to have long-term impact. As I said, you can have myocarditis, can have significant impact there. people with lung disease have significant impact in their lung function long term. And I've seen a lot of people recover from COVID that simply continue to be exhausted for a long time, even after doing just fine. The as far as the antibody, we know that many people develop antibodies, and we think that most of those are neutralizing antibodies. The question is, how long do they persist? Are they going to be immune from getting COVID again for a year, 2 years? We don't know. But people that develop the strongest levels of neutralizing antibodies tend to be men, tend to be older, and tend to be hospitalized. So it seems like if you have very severe disease, you're likely to develop significant neutralizing antibodies. If you have mild disease, or people that have very minimally symptomatic disease, don't develop such high levels of neutralizing antibodies, so they can very well be reinfected.
And can you comment on reinfection? Approximately how many cases of true reinfection have you yourself seen?
I'm not seeing, I've seen one actually. I've seen one person that I'm convinced is a reinfection because I have evidence that this person had at some point in time antibodies and got reinfected again. But I think it's exceedingly rare to see reinfection.
So for, as most of us listening are in the cardiology world, and as you know, initially there were some reports that maybe ACE inhibitors and ARBs used for hypertension would make COVID worse. And now the newer reports look like, no, maybe they're actually protective. It's been a real problem with patients calling in. Do I take my medicine? Do I stop my medicine? What do I do? Can you comment on what you think the importance of ACE in the lungs is, and if there's any concern with patients who are on ACE inhibitors or ARBs for treatment of hypertension?
Yes, I mean, I think that if your patients are on ARBs or ACE inhibitors for the treatment of hypertension or diastolic dysfunction or some other reason, they need to continue taking their medications. There's absolutely no evidence that you need to change their therapy, and there's no evidence that being on that therapy changes their risk or their outcome of disease. So I personally take an ARB and I have not changed my medications.
And I am on an ARB and I have not changed my medications either. Okay. So we have another question again about how long antibodies last after the initial infection. Any general timeline on that?
Well, yeah, I mean, we don't know because we haven't seen this virus for a long time. But as I said, people that are men, older, and people who have severe disease that are hospitalized have fairly high levels of neutralizing antibodies for a long time. And those are the people we're actually asking to donate plasma because we have used their plasma for treatment of COVID. And we haven't talked about that, but immunotherapy, plasma therapy is actually a very effective way to treat COVID. But you need to be sure that the plasma has high levels of neutralizing antibodies, and those are the patients more likely to have high levels of neutralizing antibodies.
We have a question from Dr. Gongora, who is our cardio-obstetrics expert, and she wants to know, what are your concerns about COVID infection during pregnancy?
Actually, the evidence we have till now is that COVID is not so severe as influenza or the viruses during pregnancy. There's one study from CDC saying there may be a higher incidence of women who are pregnant with COVID ended up in the ICU and being more sick. But it's pretty rare. I mean, the great majority of pregnant women seem to be doing okay with COVID. If they the worst part is if they get COVID in the third trimester, because like any infectious disease, they're more likely to go on to develop premature labor.
And are you seeing any of the prothrombogenic or clotting issues at the time of labor and delivery in pregnant women?
I have not seen that, but I can tell you that thrombogenic complications of COVID are just fascinating and something that we still need a lot more research on. But the reality is, as we have improved the management with anticoagulation and COVID, the mortality has gone down because clearly a lot of the patients were dying of thrombogenic complications.
And I will say to our participants that the organization Mother to Baby does have a COVID registry that's easy to enroll online for women who are diagnosed with COVID during pregnancy. I've already referred a couple of my patients to it. So it'd be nice to collect a lot of that data in a large registry.
Absolutely.
The last question, once you've become negative from being positive, can you become positive again? Clearly, that's a question of reinfection. Would you have symptoms necessarily the second time, or could you have positive testing and still not be actively reinfected?
Yeah, so the issue of positive testing is really a conundrum, right? Because currently we're doing PCR testing, and we know that some people remain PCR positive for a very long time, yet they're not infectious. After 10 days, you are not infectious anymore, but their positive test remains positive. And that's really a big issue, because those individuals, then you cannot, send them to nursing homes or anything like that, because they're testing positive, but they're not infectious anymore. And we really don't understand well what's happening with them.
We're seeing that also in healthcare workers, right, that can't return to work. So it's an issue. I'm sure that you're a very pro-mask and hand washing. Could you tell us what you think about the kids going back to school in Georgia and the fact that our governor still hasn't issued a mandate for mask in public places?
Well, I think that masks, we don't have a lot of tools to combat this infection, but the most effective tools we currently have are called, what I tell people is the 3 W's, right? Wear your mask, watch your distance, and wash your hands. And if you can do those 3 things, you're less likely to get infected and to infect others. So I think that I think we have a lot of transmission in Georgia. I think we all need to be wearing a mask. I think we need to also not go to crowded places, to bars, to nightclubs. And if we did that, we could bring infection rates down. And I think if we bring infections rate down, it'll be a lot safer to do many of the things that we all want to do. But a school opening without a face mask mandate is a challenge. It's like, it's a little bit of a gamble, and I think it's not going to end up well. So I'm encouraged by the fact that the governor recently has allowed counties and local authorities to make decisions about masking, and maybe we'll have school superintendents and others make face masking obligatory, because I think if we don't do that, we've shown very clearly in healthcare that by wearing masks we've decreased transmission significantly in healthcare. We got to do the same thing in schools and other institutions.
Can you speak to how important is it to have eye protection, one for the general public, but second for the healthcare workers?
Well, I think, Gina, that as far as healthcare workers, I think it's very important to have eye protection. I think in the general public, I think it's a little more controversial, but there's a nice study in JAMA about face shields in public that makes sense. And personally, if I were to get on a flight, I would certainly wear a face shield. If I were to go to a crowded place, I would certainly wear a face shield or some sort of goggles or eye coverage. I think eye coverage is quite important if you're going to be in a crowded environment, if you're going to be in a closed environment, if you're going to be in an environment that there's not a lot of air circulation. If you're going to be outside, walking in the park, you don't need face coverage. But if you're going to be inside a crowded room, I suggest you have a face cover.
All right, well, thank you very much. The tremendous amount of questions. We appreciate your insight and your knowledge and your expertise, and taking time from your vacationing and enjoying your new grandbaby down in Miami to join with us today. So thank you so much, Dr. Del Rio.
Delighted to be with you. Take care. Thank you, Gina.
All right, thank you.